Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And here we are, we're going to do another speak pipe. I was going to say we're back on the pipe, but that doesn't sound right, does it?
We are doing another speak pipe because we love them. They're great.
Yes, they're great. And so we've got some really great questions all lined up. So I don't know, Pat, let's just move straight into it.
Great. Straight away, let's go.
Hi, Dr. Pat and Brigid. My name's Emily. I'm calling from the UK and I'm a long-time fan of the podcast. I had my first baby 2 years ago. She was a very straightforward pregnancy. I was diagnosed late on with preeclampsia and had a successful induction, and she was born on her due date with no complications. My second pregnancy has not been as straightforward. My question is in 2 parts. So my baby currently is in a transverse position. What can I do at 32 weeks myself to try and get him to go head down? And if that's unsuccessful, what are my options? Obviously, I'm very much looking forward to not having a cesarean. And the second part of my question is my baby is measuring very big on growth scans, so he's currently 97th percentile. I have a test for gestational diabetes in a few days' time. Regardless of the result of that, what would the outcome there be with regards to avoiding a cesarean section? I'm thinking I probably will be induced before my due date, but what are the chances of that being successful with his current position? Thank you so much for your help.
Can you start by talking about what transverse means?
So transverse is just that the baby is literally sideways. So it's down in the pelvis. There's neither the head nor the bum, nor the feet. There's nothing much in the pelvis at all, and the baby is sitting higher up in the uterus, sideways, with the head on one side of the woman's body and the bottom and the feet on the other. It's a less common fetal presentation, but it's important to know about transverse. They won't fit out sideways. They do fit out head first and bum first, but they don't fit out sideways. And there are some important things to know if your baby's transverse. If there's a head or the baby's bottom deep in the pelvis and your waters break, then the head or the bottom will provide a pretty good a plug, and the water will come out usually pretty slowly, and it's most unlikely that the cord will fall out ahead of the baby. If the baby's transverse and the waters break, there's not much plug in the cervix at all. There's nothing much down there, and the water will come out quickly, and it's possible for the cord to come down as well into the vagina, which is a potentially dangerous situation. So when people are transverse, we talk to them about coming to the hospital promptly if there's any suggestion the waters could have broken. Otherwise, we're going to talk about the what to do for the rest of pregnancy and this issue of fetal size. In terms of the transverse presentation at this stage, the most common thing to do at the moment is not much. The baby's position right now is one of fetal behaviour. The baby's presentation is up to the baby at this stage. Most of these will correct themselves and the head will come down, and that's brilliant. Occasionally they turn around the other way and the bum comes down, which is less brilliant. And then occasionally the baby remains transverse approaching term. So if the baby is transverse approaching term, then birth would be best done by cesarean section. You can't have an induction which is still in the transverse position, so baby won't fit out, and it's certainly not going to move once the waters are broken. Yeah, so they won't induce you if you're still transverse. But if the baby can be moved into or moves itself into a head first position, then induction would be preferred to a caesar for no reason once the problem had been fixed.
Yeah. And that she'd had a vaginal birth previously.
Yeah.
Yeah.
So if we talk about external version, which is a procedure where you go into the hospital and they can put hands on your tummy and help the baby come around, theoretically it should be easier to get the transverse baby to come around because it's only
halfway.
Quarter turn. Yeah. Whereas a breech baby, it's a 180. And look, sometimes it works and sometimes it doesn't. Sometimes it works and you say, fine, let's sit back and wait for you to come into labour or induce you next week, and it goes back.
It goes back to transverse or whatever. Yeah.
But in skilled and experienced hands, external version can be done, and as an alternative, a caesarean section.
At what week of the pregnancy would an external
it's a bit different in different units, but you don't want to give the baby tons of chance to come back the other way. The issue here is one also the baby's pretty big.
Big, yeah.
Yeah, and so we don't do too many off the bat Caesars for big babies because ultrasounds can be inaccurate in the third trimester, and there's no reason why a woman might not be able to have a big baby vaginally in some circumstances. So if the baby is really big, with a predicted birth weight in excess of 4 kilos, then we can talk to that woman about a potential benefit to an induction to cut off a few weeks of fetal growth at the end. But that has pros and cons. Occasionally you would do all of that and baby comes out, it's not as big as we thought it was.
Yeah.
All right, so this is a complex discussion. Yeah. So there's a few steps here. Does the baby correct its own presentation? 2, are we considering external cephalic version? And then 3, once that's been done or the baby's corrected its own, when should we get on with having this baby? Bit to discuss. Yeah. One thing's for sure, serial ultrasound scans being done in the same ultrasound department, ideally by the same technician, is more accurate because we don't want to interfere if the baby's not really very big. And a common cut-off of that is a predicted date at term in excess of 4 kilos. Yeah.
And we're not sure how the NHS, if that's the system that she's going through in the UK, works with having for her to ask for the same technician to do the ultrasound.
Yeah, well, I think in good units that's something that would be done if possible. It's not always possible. That person might be gone on leave or something. But it is known to affect the accuracy. Yeah. And so, may not be able to demand that to happen, but knowledge is power. It's worth knowing that it's a thing.
And Emily, even though your wish is for another vaginal birth, you might want to listen to our caesarean section episodes, so you're well versed in, that as an option as well.
Yes, let's say that becomes, let's say the baby is in a persistent transverse presentation and an external version is thought to be unsuitable or it's done and it's unsuccessful, then caesarean section is definitely the way forward, and then you might as well have the best one of those you can.
Yeah. Which could be a maternal assisted caesarean, or there's options that you can have when you're planning to have a planned section. So
that's right.
Good. Well, good luck.
Quick question. Are you tired of the news? Do you want a podcast that isn't self-improvement? Come get unleashed. It's funny.
I also think that underwear is sort of almost like a new marriage. Like it starts off, it gives you the best of what it offers at the beginning.
It's unhinged.
I have a bit of a thing for my friend's husband's salami.
Oh, hello.
It's not here to teach you anything.
I need to make sure he looks at me. One side, I'm going to make a sign. This is what I married because I didn't meet you in time.
Yeah, right.
The other side, with pointing to my son who's 12. Look what we could have had, Lewis.
Yeah, I love it.
It's a good time for Gen X. So search Unleashed wherever you get your podcasts. New episodes every Tuesday.
Rightio, Pat. Let's move to this caller.
Hi, Dr. Pat and Brigid. Thanks so much for your podcast. I am not currently pregnant, but I'm hoping to conceive in the next 6 months, and I'd love to know a little bit more about the different categorizations of medication in pregnancy. I'm currently taking a blood pressure medication for migraines that, from my research, I can see is listed as category C in pregnancy. As a bonus, I have found this medication to be incredibly helpful for anxiety too, and it has improved my overall well-being and quality of life drastically. In an ideal world, I'd love to keep taking it during pregnancy, and I've talked to a provider who gave me a similar but different medication to try that has a slightly better safety profile, but unfortunately it caused me to faint. From my understanding, category C essentially means that there's limited data available in humans. However, animal studies have shown some adverse effects on the fetus, and the last thing I would ever want to do is harm my baby. But I know that a lot of the time in pregnancy, it's a risk-benefit analysis, and I do feel that this medication has become a really important part of my overall health and well-being. I would love your advice and recommendations. Thanks so much.
Great.
What
Medication.
a terrific question, and yeah, fantastic. So, drugs in pregnancy. We've got a system in Australia. Other countries would have their own. That would be very similar. Ours is A, B, C, D, X.
X.
And A's are fine, but B's are in common use. They just don't quite have the evidence to strictly qualify as an A. C's are interesting. There are a number of C medications that we do use in pregnancy because the C classification includes some studies that have shown issues in animals. The significance of those for humans is not well understood. So there are some C's in common use. D's are really not to be used, and X's are don't use under any circumstances. What we would very commonly do with somebody who was on any medication, what I love is that if someone's had a look at people's medications before they're pregnant.
Yeah, so she's 6 months. This is good.
Yeah,
she wants to conceive in 6 months.
Yeah, so a plan is fantastic. And this is often well within the expertise of the family doctor GP to have a look at what we're on and use that 6-month pre-pregnancy visit to also have a look at the cycle, the partner's health, body weight, and do a pre-pregnancy genetic screen. Typical, highly valuable preventative pre-pregnancy visit. So when that gives a chance to look at those medications and think, okay, well, what's our plan? Because some of them are some of the even more dangerous or potentially dangerous in pregnancy ones are perfectly fine to use right up until you're pregnant, and it's just nice to have in advance a plan. Once I get that positive test, what do I do? Stop taking that one and start taking another one. Stop taking that one and observe. Continue that one maybe. So there's a plan is called for, especially if we're on something that's C, D, or X. The need for antihypertensive medication in pregnancy is hard to predict. And sometimes if someone was on something that we would really rather they were off, it might be quite reasonable to stop it and observe, or to stop it and use some of the old-fashioned category A antihypertensive medications that we do find great in pregnancy because they're super safe, but they're probably not something a young person with hypertension would have been trialled on before because they're pretty much only for pregnancy use. So there's plenty of options, and I think the caller's probably got more options than she thinks she does.
Yeah. And also, she's taking that hypertensive drug for migraines.
Yes.
And some people, their migraines go away anyway.
100%. Some people get worse, some stay the same, lots get better. And so you might say, well, hang on a minute, if I'm not getting them in pregnancy, perhaps I don't need to prevent them. And that would be taken into the consideration. As the caller said, it's a risk-benefit analysis. Yeah.
If she said, okay, I like that idea, maybe I will just see how I go in pregnancy and not take that category C drug, when would she actually stop it? during the early phases of conception or after she knows she's conceived?
You
or?
would stop it when you got a positive pregnancy test, as per the plan you'd made previously with your doctor, and then you would say, right, let's see what the first month brings. If I'm fine, I'm fine.
Yeah.
If I'm not, and I've got constant migraine, well, we're going to have to use something. Let's use the safest thing.
Yeah.
But it's really nice for everyone to have had a look at all of this in advance. Yeah.
So the one that they put her on that caused her to faint, it might be that there's just another one that
Yes,
she could
there
try.
could be tons of other ones, exactly. Yeah. And do we get advice from a general physician, from a neurologist? Let's get those first.
Yeah.
Yeah.
Great. And if anyone's at this stage and they're thinking, oh, look, I want to be pregnant within 6 months, I do recommend that you pick up our Getting Pregnant program. It's, I think, $67 or something, and it goes through all the steps to maximise your fertility, including what to ask your GP, the pre-pregnancy checklist, other things that you can put into place to get you best ready to get pregnant. And I'll put a link in the show notes, or just jump on our website, growmybaby.com.au, and it's there on the homepage. Okay, let's move on to our next caller.
Hi, Dr. Pat and Brigid. Thank you so much for your podcast. It has been such a great source of support and knowledge throughout the past couple of months. I would just like to ask regarding anembryonic pregnancies or blighted ovums. I recently had a early pregnancy loss in November. It was what you could call a chemical pregnancy. It was very early on when we lost the pregnancy. After November, I haven't had my new menstrual cycle, so I haven't bled yet. And we recently found out that we were pregnant this January without an exact LMP. So we went in for a dating scan, and we found a pregnancy sac, a gestational sac, measuring at 21 millimeters, so around 7 weeks and 1 day, with no fetal pole or anything inside. I would just like to ask, what are the chances of actually just being very much earlier on in the pregnancy than what the scan shows? If there are any chance of further development, or if that's pretty much it.
Oh,
I'm sorry to hear about the trouble that you're having. I can hear it in your voice. So the only good news here is that there is a clear system for working this out. And it's an ultrasound-based system, and it's very accurate. So, once upon a time we would have said, well, you should be this many weeks based on that period, and there's nothing in the uterus, must be a miscarriage. But there are problems with that system, including that in this particular case we don't know we really can't calculate the exact last menstrual period, so it's hard to know exactly how pregnant we are. Thankfully, the ultrasound-based system is not really terribly important how many weeks you are supposed to be. It's more about what the ultrasound says. And what they've done is they've been able to establish a set of ultrasound rules that say if the sac is this big and it doesn't have a fetal pole inside it, that's always a miscarriage. And the way they determined that when they were working these rules out is that they basically said that nobody who had a sac that big without a fetal pole inside it ever went on to have an ongoing pregnancy. So let's call it there and say from now on we can be extremely confident that if that's the picture, this is a miscarriage and we can call it. Similarly, if there's a fetal pole and it's a certain size without heart beating, again, nobody with that picture ever went on to have a healthy pregnancy. Therefore, we know we can call it there. And there's a whole set of rules about how big the sac is whether or not there's a yolk sac inside it, whether there's a fetal pollen, whether that fetal pollen has a heartbeat. And if we follow those rules, we don't give inaccurate advice or get into trouble. So if people are interested, the ones we use here are published by the Australian Society of Ultrasound in Medicine, and you can Google ASIM miscarriage guidelines, and it tells you. Yeah. So we interpret those now. If you have a miscarriage, if you have a potential miscarriage situation, and you don't meet the guidelines for miscarriage, then we don't do anything. You got to do another scan.
Another scan. Wait.
And they tell you when to do the next scan. Rescan in so many days, so many weeks. And unfortunately, you can get stuck in a grey area where it's probably a miscarriage, but we can't call it until you've been rescanned. And sometimes the recommended rescanning is 11, 12, 14 days, which is tough for people. Yeah. But it's an ultrasound-based system. It's accurate and can be trusted. And takes the problem out if you don't know off dates how pregnant you were in the first place. So your caregivers would be able to have a look at that, see where you sit on those guidelines, and give you some recommendations that you can trust.
Yeah. All right. Well, we've got our fingers crossed for you. Good luck with that.
All the best. Pregnancy loss is such a difficult time, but the very least we want people to be able to do is understand that we're sure. Yeah. And that if we're proposing that if the miscarriage is diagnosed, that's accurate.
Want to feel good more often in 2026? Hi, we're here for you. Move by Mamma Mia helps you fit movement into your everyday, giving you more of me time whenever you need it. From strength and cardio to yoga and Pilates, with workout plans that fit every space, every body, and whether you've got 10 minutes or 40. Start 2026 with enjoyable movement from just $9.99 a month. Mamma Mia subscribers get unlimited access. Head to move.mamamia.com.au and use MoveMe to get $20 off an annual subscription.
Yeah. So let's move to this caller, Pat.
Hi, Dr. Pat and Brigid. I love your podcast. My question today relates to number 1, cervical cerclage success, and number 2, uterine fibroids in pregnancy. I have had a cervical cerclage placed at 21 weeks after my cervix had been found to shorten quite dramatically. I wanted to understand what the success of that is. I've been told I don't need to go back in again until I'm 36 weeks for another scan or any more checks around that unless there's complications. I also have seen on my most recent report at 22 weeks that my fibroid, which is anterior and is in the wall of my uterus, from my understanding, has grown again. So it's now 6.5 by 6.7 by 3.3 centimetres. And I've seen that it's retroplacental. I'm quite worried about that, and there's actually no more monitoring that's going to happen until my 36-week scan. But when I Google that, there's a lot of complications. I just wanted to have some more understanding around retroplacental fibroids as well, and what that could mean in your experience for my pregnancy outcomes. Is there anything I need to look out for? Thanks so much for your time today, and I look forward to listening to all the rest of your episodes as they come along.
Big questions there.
Yeah, complex situation.
Very complex.
So the use of cervical cerclage is, it's not a common thing to need to do, but it's certainly a well-established technique that if the woman's had a history of painless second trimester labour consistent with cervical insufficiency, that towards the start of the pregnancy we might literally sew the cervix closed. And it can help the cervix be supported, stay closed, and get the pregnancy, if not to term, then right out into the third trimester, where even if the cervix then opens, it's not such a problem for the baby. Then there's another scenario in which we're watching somebody with an ultrasound program called cervical surveillance, where we've got someone who thinks at risk of this for whatever reason. Then the cervix on ultrasounds is being seen to get progressively shorter, and there's a protocol. If it gets to a certain shortness, we should put a stitch in before it starts to open. And so, our callers had that second scenario, and things seem to be going well. Once the stitch is in, we don't tend to do a ton of extra surveillance because we don't want to be doing internal examinations so much and disturbing the environment around the stitch. And if we keep doing ultrasound, there's not too much extra it can tell us about the stitch other than that it's sitting there, and we're just hoping that it helps the cervix hold on for much longer. Obviously, if the woman's got bleeding or a waters break or something like that, that's different. But multiple extra ultrasounds may not tell us that much after the stitch has already been put in. The fibroid's an interesting situation in that the fibroids can be important in pregnancy. Even young women in the pregnancy years can have uterine fibroids, although they're much more common in the post-pregnancy years. And occasionally they're relevant. Depends on a lot of things. It's only of some interest that it's in the bit of the wall that's behind the placenta. What's more important is where it is in the wall. So it's more likely to cause a placental issue if it's sitting directly under the placenta on the side of the uterine wall that's in the cavity with the baby. If it's in the wall itself, the placenta will still be nicely attached. And if it's poking out of the uterus on the other side of the uterine wall, then it's unlikely to be relevant at all. So doing ultrasounds and watching the size, again, we really have to have a clinical question in mind. We need to be saying, is whatever's going on with this woman right now, let's say she comes in with pain or bleeding or something, is that something to do with her fibroid? Fine, let's have a look. Or is the growth of that fibroid going to obstruct a labour? Let's say the fibroid's really low and we think if it gets bigger, the head won't be able to get past. Then fine, we'll do some extra scans. But if it's just there and we know it's there, then but it's not doing anything important or bad to the pregnancy, then we're likely to do a scan, usual 20-week one to look at the baby's anatomy, and then they'll see the fibroids there, and then again sometime in the third trimester just to make sure that nothing's radically changed while we weren't looking. Yeah.
It seems big. Is 6.5 by 6 by 3?
It's big-ish, but it depends entirely where it is. Like if it was right down near the cervix blocking the baby's way out, that's hugely relevant. If it sits outside the uterus on a stalk, dangling outside the uterus, it's not relevant at all.
What's the management for fibroids for her from now on?
It depends where it is and what it's doing.
Yep.
So let's say that we have this baby and everything's great, but someone's got a fibroid identified during the pregnancy that didn't do too much bad to that pregnancy but is in a problematic position or size where we think it's going to stop that woman getting pregnant again or cause a major problem in the next pregnancy, then between pregnancies it can be removed. And then if that's not necessary, you just have all your babies and then see what sort of uterus left at the end.
Yeah.
What'll often happen if there's a lot of fibroids is that woman might, after she's finished her family, get the return of menstruation after the last baby. It's heavy and problematic, and then we would manage that like we would manage anyone with fibroids, discuss treatment options and make a plan.
Well, thanks for listening, everyone. We hope that, there's something in all of those questions for everyone, I think. So hopefully it's lots of useful information for you to have during your pregnancy or even trying to get pregnant. And if you like the information that we give, we invite you to join us in our program. It is a program that can take you from the first moment that you're pregnant right up to 6 weeks postpartum, and you get weekly information that is based on as if you were seeing an obstetrician such as Dr. Pat, with lots of information about what to expect at each week of the pregnancy. It's not information that we've seen anywhere else. We know that our people who do the program really get a lot from it. We get some really great feedback from it. So we invite you to join us in that program. The link is in the show notes and also on our website, which is growmybaby.com.au. So next week, we're back in your ears. Keep well, keep growing your babies, and bye for now.
Thanks for listening, everybody.
Hey, even though Dr. Pat is, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.